Good morning, everyone. My name is Claire and this is Joe, and we're from the CHO7 Tala team, and we're going to speak to you today a little bit about how we've developed links in the community and the hospital in our area, and how our team acts as the interface between those services. We'll just quickly first take you through a background to our service, set the scene. It's not quite as grand as Australia, it's just little old Tala, but we'll discuss then about the services that we interact with and how we've developed those links throughout the last 10 months. So we've been working since February January really of this year. Everybody's been on post properly since February. So you can see there, again, a little bit different from Australia. We've got Tala on the left in 1956 when there was only 710 people living there. And then fast forward 60 years and we're in excess of 100,000 people. Young families moved out from the city centre and are now living in the suburbs of Tala, which I think someone mentioned earlier, Tala is now the city centre as well. So with them, obviously, their young families have now aged, and this is the ageing population that we're dealing with, and that's why Tala was chosen as one of the pilot sites for last year for the integrated care team for older people. As you can see on the figures there, the blue numbers are the amount of people over 65 presenting to emergency department and admissions, and then the red is over 80s. So we're increasing year on year, and we know our hospitals are at capacity, and we know people are in A&E for a long time, so we wanted to develop a service that would prevent some of those backlogs from happening. Just to put it into context as well, we're CHO7, so we're actually the biggest CHO in Ireland. I think that's old data, but I think we're still the biggest. So we cover quite a wide area. So anyone who's linked, any older person linked to Tala Hospital that lives in CHO7 could be theoretically under our care. This is our team. So we're made up of a rotational consultant geriatrician from Tala Hospital. At the moment that's Dr. Collins, but they rotate every 4 months, which is great because we get viewpoints from all the different consultant geriatricians. Joe beside me here is one of our case managers, and unfortunately our other case manager position is vacant at the moment. If anybody would like to join, we'd love to have you. I won't poach any other staff from other areas. We've got Mary, who's our admin assistant, and she sits in Tala Hospital, which in itself is a brilliant link because we can get access to all the data in Tala Hospital. Hopefully now going forward we'll be able to get that remotely, but for the time being Mary's a very strong link for us, and she does all our appointment bookings and our stats returns as well, which is brilliant. And then finishing up the team are myself, Anna and Martina, who are I'm the physio, Anna's the OT, and Martina is a social worker on the team. So we're based, like PJ said, in a primary care centre in Tala, within 500 metres from the hospital. So we're really, really lucky. We're really well placed in being able to pop into the hospital whenever we want to and annoy them. They can't ignore us too much. This is our integrated care team service objectives that were set up at the start of this year. They're constantly being reflected on, and we, trying to keep these in the forefront of our mind every day. It is difficult to standardise services, and that was alluded to earlier, in integrated care across the country, and we've been in touch with other members of our disciplines, and we know it's running differently in different sites, so we just try and keep our service objectives in the back of our mind when we're seeing our patients. So for older people in CHO7, we want to have timely, efficient and coordinated services for those older adults that have complex needs. We want to anticipate potential crisis situations and plan their care from the community. We want to minimise avoidable acute hospital admissions where possible, and if they have been admitted, we'd like to facilitate appropriate timely discharge back home. We want to prevent premature long-term care placement, and if it is needed, that we'd facilitate that from the community or expedite it from the community, rather than having a person sitting in an acute ward for 3 or 4 months waiting on a long-term care bed. In the future, like the Australian system, we would be keen to have a link person between the long-term care residents and the hospital, again to avoid unnecessary admissions to the hospital for things that could be dealt with in the nursing homes. So this is just a brief overview of our referral pathway, and again I know I'm conscious it's different in each different area, but we actually have a centralised place where all the referrals come from. So at the moment it's from a GP, and if public health nurses or health and social care professionals have a concern in the community, they can discuss that at their primary care team meeting and discuss it with the GP then, and they can refer into us. We do get phone calls directly from public health nurses, but we just direct them back to get a full picture from the GP to send in a letter through the usual way into Tala Hospital age-related services. A geriatrician will triage all the referrals every day and send them to different appropriate teams. So there's a falls clinic in Tala, there's a memory clinic, we have a day hospital, stroke services, and then there's our integrated care team as well. So if it's appropriate for our team, that file will make its way over the 500 metres across the road to us with a Tala MRN, and it will also have any recent clinic or inpatient notes that are relevant inside that chart for us so that we can see what's going on in the hospital. And then we start the information gathering. So we assign the person to a case manager or a key worker. So if the person has problems with falls or ADLs or functional problems, either myself, the physio, or Anna, the OT, will probably do the first assessment. If it's more of a social issue or a nursing concern or some care or stress, our case manager or the social worker will do the first assessment. But it's the same first assessment that we do for everyone, and they get the same screening test done, which I'll talk about in a bit. The information gathering is a really, really important part of our role. It's a lot of phone calls and emails and ringing back and leaving messages, but we just get the true picture of the person from their community services, their GP and the hospital. We gather that all together, and then we do that initial comprehensive assessment. So it is a comprehensive geriatric assessment done by one of the four of us in the community, and then we'll bring it back to an MDT once a week on a Monday, and we decide if they need to be seen by a geriatrician. They might have seen one recently if they've been in the hospital, or they might have seen a GP who's happy enough with their medical care, but there might be some other issues. But if they do need to see a geriatrician, we have a rapid access clinic in the day hospital in Tala Hospital, which it's on every Tuesday. So if we talk about them on a Monday, they can be pulled into that clinic on a Tuesday and seen very, very quickly. We'll develop an action plan based on their needs, and from there we do some interventions, either directly ourselves or refer them on to appropriate interventions. And then when all that's finished, a discharge summary goes back to the referrer, it goes to the GP, it goes to the consultant or the person's medical notes, and it might go to the community physio, OT, speech and language or dietitian. Whoever has been involved in the past will all get a copy of what we've done on our intervention. And generally that lasts about 6 weeks, but it can be from 2 weeks up until 2 months for some people. So we obviously work with an awful lot of services to be able to coordinate the care as well as we have been doing for the last year, and we're lucky in a way that where we are in Tala there is a really, really good community ethos in Tala. There's already really good existing voluntary resources, community groups and a good sense of community, but I suppose it's not the same throughout all of the areas that we cover. So we do cover 4 different local health areas: Dublin South, Dublin South City, Dublin South West, Dublin West and Kildare West Wicklow, which is a big massive area to cover. So it's just, Tala area itself is quite good, but some of the other areas don't have the same community services set up, so we can see some discrepancies there. So on the slide there you can see there are just some of the services that we interact with on a daily basis. Our team itself, obviously we have links amongst ourselves. So when we first started, we needed to get to know each other's roles, what we could do, what we couldn't do, what we'd like to do, and where we saw this project going. We were one of the first in the country to get started, so we had very little to draw on. So we had a lot of meetings at the start to try and familiarise ourselves with each other. We developed our assessment tool that I was talking about. So it's a 15-page document that takes about 2 hours to complete. And there's different parts of all of our interdisciplinary roles on that assessment. So we had to take some time at the start to develop those links with each other, to teach each other how to do different screening. So for example, I can do an MMSE, Joe can do a timed up and go, which is a physio measure. Anna can do some questions about addiction and some social issues, and then Martina's able to check about somebody's pressure relief and their risk of developing a pressure sore. So we're all very well trained on how to screen, but obviously if somebody needs a more dedicated intervention, that person is referred to. All of our documentation is in one file, which is brilliant, and anyone who's worked in primary care before will know you've got separate physio notes, OT notes, public health nurse notes, and you'd never see the GP's notes. So we still don't really get to see the GP's notes, but we do get to document the rest of ours together in one shared document. So I can see what's happened yesterday when the social worker's gone out to see a patient that I'll know maybe not to bring up something that they're upset about, or if they've had a fall, I'll know even if I haven't seen them in the office, I'll know. Like I said, our weekly MDT is brilliant. It's on a Monday, it sets us up for the week and we know exactly what we're doing, and every new case that we see gets discussed at that meeting. So if I think I'm doing a great job and I've linked everyone in, I'm usually certain that somebody will remind me that I haven't done some other aspect, which is great. It means the person's getting a really holistic care and a really good action plan developed for them. And another great resource that we use that links us all together is our shared drive on the computer. So it's a secure place that we can store all of our assessment forms. We've got a contact details database of all the different staff in the primary care areas that you can just go to really quickly, and you have a mobile number you can ring without having to, go through health centres or look up different people's numbers. And Health Atlas is another really good resource that we use to know which one of our 4 areas that a person falls into and where's the nearest health centre that we should be calling. And of course, we store our stats on our shared drive, which I'm very excited to hear the updates on later, because we did go in and meet PJ and D and the gang, so we know it's an issue for everyone collecting stats, so we want to make sure we're collecting the right thing. Then our biggest, so one of our 3 biggest allies is Tallaght Hospital. Obviously they're age-related services, so the services we deal with as a team are the inpatient, the outpatient, day hospital, memory clinic. I've forgotten Falls, so I hope Dr. McElwain's not around to give out to me. And obviously we interact with different people like consultants, registrars, nurses, and the whole health and social care professionals. We have been really lucky to date in that we've had a registrar on the medical team with a consultant, so again, sometimes you can't get a consultant because they're very, very busy, so the reg has been always really good in being able to pick up the mobile phone too. Our integrated care, our rapid access clinic, is actually based in the day hospital in Tallaght, so we've got really, really easy access to tests, to investigations and to medical staff if we need them, and also if we need to refer them into day hospital for a period of rehab, they can go in there too. We have a representative from Tallaght Hospital on our governance group and also on our local implementation group who we meet monthly. Again, that top-up, top-down type of, or bottom-up, top-down system of trying to communicate ideas and what's happening on the ground up and down. They know about our referral pathways. They know by now who's a good candidate for our service and maybe who's not so good of a candidate for our service. We go to, one of our team is represented on each one of the inpatient, or each one of the Tallaght Hospital meetings for age related. So we go to the day hospital meetings to see how our patients in day hospital are getting on in there, or if some of our patients are coming from the inpatients, at least we have notes on what's happened on the inpatient side too. Recently we standardised our assessment between ourselves, our own team and the day hospital team, which is a really, really massive step forward. The older person we see in the community spending 2 hours getting all of this really, really important vital information can then be transferred on into the day hospital, which means they don't have to repeat themselves. And we know from Nora that's one thing older people don't want to do and shouldn't have to do, is repeat themselves over and over again. And until we do get a shared, a national shared e-documentation, that's the way we're going to have to do it. But it's now standardised, so likewise if they see they get their big workup in the day hospital and come out to us, we don't need to ask them all those questions again. We have it there in front of us. And then again, when we're finished all our interventions, the discharge summary is filed in the Tallaght Hospital notes. Another massive help and asset to us is primary care. So like I said, we cover 4 areas. Now we don't cover much of Kildare and West Wicklow because Tallaght, they're covered by NACE, but some of North Kildare we would, and West Wicklow as well down the N81. And obviously we're linking on a daily basis with PHNs, community RGNs, physios, OTs, social work, speech and language therapists and dietitians. Even though there's no SLT or dietitian on our team as such, we have very strong links with the ones that are in the community. And also voluntary organisations are really important too. And Jo will talk about them in a bit. Our again links are the general manager in primary care is on our governance group and our implementation group, so she gets to hear everything that we're doing and not doing. And we have gone back as individual disciplines to our colleagues in primary care to explain our team, to explain what happens and how to get in touch with us or how to get somebody referred into us. And again, the discharge summary, which probably is a bit different to what used to happen, is you'd never hear as a primary care physiotherapist, what would have happened in the day hospital or what would have happened at a consultant visit. So now you can, or they can. And the last person I'm going to talk about, then I'll pass it on to Jo, is just about our GPs. So obviously they're a massive source of referral for us, so we had gone out, myself and Dr. Kennelly had gone out to meet some of the local GPs at their meeting, again to explain what we've been doing to date, what's worked, what hasn't worked, what type of patients are really suitable to get into us as soon as possible, to put them for the attention of our team so we can get out to them quicker than having them wait to see a general clinic. And then we would keep close liaison with them throughout the episode of care. So again, if a consultant has changed the medications, we can be straight on the phone to let the GP know or let the pharmacist know. And then again, the discharge summary is then back to the GP. So I'm going to pass it over to Jo just to talk about some of the other services.
very much, Claire. I'm just going to talk to you about other community services that we link with. So we also work with psychiatry of later life, palliative care, the disability services and the county councils. For the first three on the list, referral is through the normal route, which is through the GP or the consultant. And we continue to liaise with these teams to ensure integration of care. The social worker on our team attends at South Dublin Age Friendly County Alliance, and we also liaise with different departments in the County Council, for example the maintenance department, the grants department, the social work department. Respite, I'm sure many of you have seen the programme on Tuesday on respite care and the carer stress that is in our country. We have linked with all the nursing homes in our area about respite care, and as in every other area we have a big shortage also in our area. We have requested a designated respite bed for our team and through our business meeting, and we're hoping that we will achieve that. We have worked hard to try and expedite long-term care from the community. When we receive a referral, we go to the home and do the assessment at home, and we arrange a rapid access appointment for the patient to see the geriatrician, either in our clinic or if they are unable to come in, we go to the home. The geriatrician then provides the letter that is needed if the patient is deemed suitable for long-term care, and we expedite it through that way. We complete a SAT assessment, and the families, as usual, complete the financial side, but the social worker on our team is there to answer any questions. Home care packages are applied for through the normal route. For example, in the community, it's usually applied for through the public health nurse, and in the hospital, it's through the medical social worker. It became evident very quickly after we began that we needed access to emergency hours. So we met with senior managements from different areas to access these hours, and we have succeeded in developing a pathway for this. We have still a few wrinkles to iron out. It's easier to get a home care package for somebody who, emergency hours for somebody who already has a package in place, but it takes a little too long still for somebody starting from scratch. We also attend the home care package meetings where different clients are discussed. Day centres, we have visited many day centres in the area, both Alzheimer's day centres and regular day centres, and we liaise closely with the public health nurse to access these centres and have built up relationships with the Alzheimer's Society and these centres. Plans for the future, we've all received lovely new Surface Pros and smartphones, which enables access to ICT on the go. And we met with the ICPOP national group about developing a software to support our team. The good news also is that a third case manager has been sanctioned to cover nursing homes. We also have one Parkinson's group up and going at the moment, and we're hoping to standardise that across 3 areas. And we're hoping to develop a dementia carer support group going forward for 2018 in Dublin Southwest area with Tala Hospital and the Alzheimer's Society.